Welcome to QD Clinic, brought to you by Room Now Live. I'm Jack Cush from RoomNow.com. Our case today is My Acute Gout, also known as why I would never use Colchicine. So, a patient comes in, let's say he's 50, let's say he's Caucasian, and let's say he has a diagnosis of gout. His diagnosis of gout was made 3 years ago when he presented with podagra and a uric acid of 8.5, and then went on to have several attacks over the next few years, each attack lasting 5 to 7 days, usually being the MTP, the tarsus, and then lastly being the knees. He comes into clinic presenting with an olecranon bursitis after having had a recent podagra attack, and after having stopped allopurinol, which was started in him to obviously reduce his incidence of gouty attacks. So we have a fellow presenting with an acute attack, now an acute bursitis. It's red, it's swollen, it's tender, it may have some nodular stuff on the inside of that olecranon bursa, which is fluctuant, suggesting he may have a total body urate load that's higher than we may think. And it wouldn't be surprising if we got labs today, which we did, that would show that his uric acid is normal, because 40% of acute attacks will have a normal uric acid. So he has been sort of self-managing this with an old prescription of colchicine. He's been told to take it one pill when he gets an attack, and then take it an hour later, and then he can take a third one, but no more than 3 a day until he is better. And he says that's worked kind of well for him. He's gotten a little bit of diarrhea. He's run out of his prescriptions. He hasn't gone back to his doctor. And the question is, how would I manage him? How did I manage him? Number one, I stopped using colchicine when colchicine went from 4 cents a pill to $5.50 a pill, $5.50 a pill. And now that it's generic, it's down to about $1 a pill, which is still about 20 times too expensive for a drug that's been around for as long as dirt, basically. It's time honored, 200 years of showing that gout, that colchicine works. When you give it as some kind of bark extract or as a pill that you can buy from the pharmacy. But it also has 200 years of a storied history of toxicity. Even homicide and suicide by colchicine. IV colchicine was taken off the market because it was too toxic. And frankly, you don't need colchicine to manage gout. It's an historic drug. I don't use historic drugs to manage my modern day medical problems. If I did, I would just be writing prescriptions for penicillin, colchicine, and steroids. And I write for almost none of those. They're drugs that are so much better, so much more efficient. So an acute gouty attack, in my book, should be managed by 1, confirming the diagnosis. 2, using steroids. You can use intramuscular steroids, you can use oral steroids. Use a big dose, use it for a few days. If you get it early enough, you need treatment for 3 days, 5 days. If you get it after they've been going on for 5 to 7 days, you might need it for 7 to 10 days to make a monoarticular attack go away. I tend to use prednisone 20 milligrams a day. I can go as high as 30. I can start out with a Decadron shot followed by 15, 20 milligrams a day until they're better. And then you have to figure out what you're going to do after the acute gout attack. If I can't use steroids because they're a brittle diabetic, because they can't take steroids for some reason, then nonsteroidals are highly effective. You do worry a little bit about renal toxicity, destabilization of unstable heart disease and heart failure. But honestly, they're just going to get 5 days of a nonsteroidal. And that usually works really well. Use big boy anti-inflammatory doses. That's 1,500 of naproxen, at least 1,000 of naproxen. Come on, none of this 220 stuff. And then if you need to, I wouldn't use short-acting nonsteroidals like ibuprofen. I might use meloxicam, 15 milligrams once a day until they're better, etc. So it's basically steroids, and nonsteroidals. And if you can't use that, you could use colchicine. IV's not available anymore. and you got to give enough of it probably to cause diarrhea. But nonetheless, you could use it. But I honestly haven't used colchicine in a long time, and partly because of the ridiculousness of pricing, partly because of the toxicity profile. I do have a few patients who do take colchicine, usually for an autoinflammatory disease like familial Mediterranean fever. I send them to Canada, to one of the Canadian pharmacies. Ask me, I'll tell you which one I might use. I don't want to say it here. Bernie Sanders may either endorse me, and someone else may crucify me for sending my patients to Canada, where the drugs are illegal and God knows very harmful and illegally made. Well, they're just the same thing as we can get here. You can get drugs fairly cheap there. Cheap ways of getting drugs would be to go to Canada. Another way would be to actually use a good RX card, or to actually call the pharmacist and figure out a cheaper way to get whatever drug that it is that you want. Anyway, that's it for this edition of QD Clinic. Room Now has a fabulous session on spondylitis that is going to be led on Sunday by Atul Dayadar, who's going to talk about all the latest updates on new therapies, IL-23, IL-17. It's really quite impressive. Artie Kavanaugh is going to talk about something you've never heard of but would always wanted to know, and that is enteropathic arthritis, meaning IBD-associated arthritis, diagnosis, management, clinical considerations. And then Walter Maximovich from Edmonton is going to talk to us about imaging, both radiographic and MRI imaging, and all the mystery around SI joint readings on MRI. There's a lot of new information there. Again, come to Fort Worth on this meeting March 13, 14, 15 for a fabulous set of lectures, including ones on spondyloarthritis.